Okay, we're going to go ahead and get started now. Well, I say that every time, don't I? We're going to take another look this week on the muscles in the human body. Again, this is for lab test 3. And muscles are going to be, there's only 60 muscles, and only a few of them are going to be those that we need to know the origins and insertions and actions. You need to know what the origin is, the insertion is, and what an action is, obviously. But the amount of ones where you have to have those extra bits of knowledge, I guess, unless I think I make it very clear which ones you need to remember. So, okay. Any questions on anything? Lab tests 3 and 4 are not due till December the 9th. So that is the last day of exam weeks, the last day of the semester. I'm not going to beat that into the ground again, but that's, that's a hard and fast deadline with no extensions. So plan your time accordingly and balance your schedule so you can get everything done leading up to the final exam. And having said all that, I'm going to go ahead and open this up for us. Question up here. Yes, exams 3 and exam 4, they're only, after the muscle test, there's only the test in the nervous system. There's only 4 exams in lab. And the good news is when you get into AP2, there's only 3 lab exams. So anyway, good question. Let's move on. Now I have muscles for AP1 Lab. The screen should be up. Everybody should see this. I'm going to go ahead and open it up. And there we go. Origins. Muscle origins, insertions, and actions. The list is found, again, I said this last week, in the study guide for AP1 Lab. It's found in the study guide's found in the content section. It is like the 3rd item. I think it's right after the syllabus. And you can go in there and look at muscles. Sorry. You look up muscles, you'll see a list of about 60 muscles altogether. I think that list only has 45, but there's 60 altogether to pay attention to. And I've sent you a master list anyway. And it'll show you the origins, insertions, and actions of every one of those muscles. But we're not going to do that. I'm not going to make you learn every one of those origin, insertions, and actions, but there are a handful that that I emphasize in this overview, which I think are the most important. Now, remember this. What is the origin? The origin is the attachment of a muscle to an immovable bone. The bone that doesn't move, the bone that doesn't do anything. So that is the immovable bone. Immovable bone. The other end of the muscle is going to attach to another bone, and that's going to be the insertion. So a muscle will have at least 2 points of attachment, an origin and an insertion. The bone that the insertion is on is the bone that moves. So we have a stationary bone and a bone that moves. Remember, muscles make bones function like levers to amplify their strength. So every muscle will have at least 1 origin and an insertion. They can have multiple origins, but they're going to have 1 insertion. At least 2 points of attachment. And we're always moving due to the muscle pulling on an attached bone. Wherever the muscle inserts, that's the bone that's going to move. And again, the bone that's stationary is the site of the muscle origin. The bone that moves is the site of the muscle insertion. So here we see the sternocleidomastoid. We saw this last week. The sternocleidomastoid has its origin on the sternum and the clavicle down here. There's its origin here. Its insertion is on the mastoid process. The mastoid, when those muscles contract, it allows the head to turn to the left or to the right. Yes, there's a muscle exam and the nervous system exam are due by December 9th. All lab exams are due by December 9th. It doesn't mean take them on December 9th. It means if they're due by then, that means between now and December 9th, you've got to take the muscle exam and you've got to take the nervous system exam. Doesn't mean that take them that day. Lecture exams 3, 4, and 5 are also due December the 9th. I certainly hope you don't plan on taking them all on the same day too. But, and I don't mean to be sarcastic, but the due date is the last possible date you can take them. And I expect that you are the best judge of when you'll have time to study and get and prepare for your exam and take your exam, because everybody's got things going on, and it's only going to get worse as the semester winds down. So I thought, instead of trying to arbitrarily set due dates that may or may not fit people's schedules, because life intrudes, to set it all for one date at the end, and you can figure out what your schedule is best for you and take your exam without any stress, or as little stress as possible. So, anyway, I hope I didn't come across as sarcastic, and if I did, I apologize. So, anyway, origins and insertions. There's your insertion on the mastoid process. The mastoid process moves because the head turns. When the sternocleidomastoid, the muscle in red, contracts on the right-hand side, it turns the head to the right. When it contracts to the left, it turns the head to the left. The origin is going to be on the sternum and the clavicle, but the insertions are going to be on the mastoid process. So here's our arm muscle. Again, our arm muscles. There's the brachial in between the triceps and the biceps. The triceps is down here on the inferior surface, and we have the biceps on the superior surface, and the brachial is right in the middle. There's the triceps on the left-hand side and the biceps on the right-hand side. There's biceps brachii, actually. There's the deltoid muscle, shaped like a fan or a delta on a map. Covers the top of the shoulder. It's where we get our injections. And it ends at, it inserts itself on the deltoid tuberosity of the humerus, right about here. And there is the triceps brachii. The triceps brachii and the biceps brachii are antagonistic pairs. They work against each other. When one flexes the arm, the other extends the arm. When one extends the arm, the other flexes the arm. So they work against each other. And here is the muscle that allows us to turn our wrist and open doors and turn keys and use a screwdriver, for example. It is the brachioradialis. Brachioradialis has its origin on the humerus, and it inserts at the end of the radius. And when it contracts, it allows the head of the radius to rotate around the capitulum. It gives us that rotating action we have with our hand and wrist as we turn our forearm. There's the brachioradialis. Its origin, again, is on the humerus. Its insertion is on the end of the radius, the distal end down here. And as I said, when that contracts, imagine putting in a light bulb, screwing in a light bulb, turning a doorknob, turning a key, turning a screwdriver. Turning seems to be the operative word here that we're using, but that's what the brachioradialis does for us. Okay, now let's take a look at some more of these muscles on the arm. Of course, there's the deltoid muscle. Its It inserts on the deltoid tuberosity of the humerus. It covers the shoulder. Here we have the biceps brachii on the superior surface. Here is the triceps brachii on the inferior surface of the arm. There is the teres major. The teres major is clustered up where the rotator cuff muscles are. The teres major is not a rotator cuff muscle, even though it shares a name with the teres minor, which is one of the rotator cuff muscles. Teres major is not a rotator cuff muscle. There's the brachial there for brachialis, and there is the brachioradialis. And that's always identified by these three nerve endings that come down across here. It also wraps itself around and comes down to the thumb. As I say repeatedly, if you know where your thumb is, you can identify an awful lot. You know where your thumb is, you know where your radius is. And if you know where your radius is, you know where your ulna is located underneath it. Now you see that the brachioradialis inserts right behind your thumb at the end of the radius. So later on in AP2, you'll remember that if you can find your thumb, you know where your radial pulse is located right behind the thumb. You'll know where your radial artery and radial vein are located, and you'll know where your ulnar artery and ulnar vein are located just by knowing your thumb. Okay, enough of that. So the biceps brachii is the antagonist to the triceps brachii. The biceps brachii allows you to flex your arm. In other words, you can bring your fingertips up and touch your shoulder by bending your arm at the elbow. And it's the biceps brachii that does this. The biceps brachii inserts on the radial tuberosity, and when it contracts, it pulls the radius and the ulna together up towards your shoulder. We narrow the angle at the elbows. We're flexing the arm at the elbow. We're flexing the elbow joint. So its origin is on the scapula and on the humerus, and the insertion of the biceps brachii is on the radial tuberosity. Now, its antagonist is the triceps muscle. The triceps muscle is going to extend the arm at the elbow. The triceps its origin is also on the scapula and the humerus. It has three heads instead of two because it has tri for triceps. Biceps has two heads. The origin of the triceps is on the scapula and the elbow. Its insertion is on the olecranon process of the ulna, the elbow, if you will. So you put your hand around on your elbow, and you're rubbing the olecranon process. That's also the point of insertion of the triceps muscle. And when that muscle contracts, it pulls the forearm back out. We increase the angle at the elbow. We extend the arm. So the terms are flexion and extension. Flexing, we narrow the angle. Extension, we increase the angle. And we extend our arm out by pulling on the olecranon process. There's our olecranon process right there. And there is the insertion of the triceps brachii on the olecranon. And we pull on that when our elbow is flexed, it straightens it out. We see it here. Here we see flexing the arm. We can see the biceps brachii inserting on the deltoid tuberosity right there. On this arm, we can see the triceps brachii with three heads with its insertion on the olecranon process there. So we flex our arm upward this way by pulling on the radial tuberosity. We straighten it out by pulling on the olecranon process. They are antagonistic. Deltoid muscle covers the shoulder. That's where we get a lot of our injections. It inserts on the deltoid tuberosity. It allows you to bring your arm in closer. It adducts the arm. You know, what do you need to remember? That it's the deltoid muscle, and it inserts in the deltoid tuberosity. And there's a reason I emphasized all these tuberosities when we went through bones. The deltoid muscle can flex and extend the arm. It can abduct and adduct. Abduct means to take the arm out, and adduct means to bring it back in. But let's just focus on knowing that it's a deltoid and it inserts in the deltoid tuberosity on the humerus. Okay, so now let's take a closer look at the rotator cuff muscles. We'll have to go through a couple more here, but here we have the supraspinatus muscle. The supraspinatus muscle is found in the supraspinous fossa above the spine of the scapula, located right here. There's the spine, and there's the supraspinatus. We have directly below that, we have the infraspinatus. In the infraspinous fossa, the flat area below the spine. And we have the third of the four rotator cuff muscles. We have the teres minor, directly underneath the infraspinatus, and also in the infraspinous fossa. So those are three of the four rotator cuff muscles, the teres minor. And as I said, if you have a minor, you're going to have a major. If you're going to have a major, you're going to have a minor. We saw the pectoralis major last week, and we'll see it again this week with a little hint of the pectoralis minor. Here we have the teres minor, found in the same location as the infraspinatus. It's on the infraspinous fossa. The teres major is not a rotator cuff muscle. It just happens to share the name teres with one of the rotator cuffs. Now, all the rotator cuff muscles originate, all four of them, and the one you can't see is the subscapularis on the other side. All four originate on the scapula. Their origin is the scapula. They all insert on the head of the humerus, and their action is to allow the head of the humerus to articulate at the glenoid fossa. Of course, there's the deltoid muscle covering the shoulder itself. So the rotator cuff, these four muscles come together. They form a cuff over the head of the humerus. The humerus fits very snugly up against the glenoid cavity because that isn't much of a cavity. It's not much of a socket. So we hold it, it's more of a fossa. In fact, it's often called the glenoid fossa. The four muscles come together and form a cuff around the edge of the humerus and hold it snugly against the glenoid cavity, and also allow the humerus to move in almost a full 360-degree range of motion, because you can pull in different directions at the same time, and the arm will move around there and yet be held firmly in that the cavity. The four muscles are the supraspinatus, the infraspinatus, the teres minor, and on the posterior surface we have the subscapularis, found in the subscapular fossa. So now we look at the posterior surface and we see the subscapularis right there in the subscapular fossa. Of course, for frame of reference, there's the biceps on the anterior surface, and the Triceps Brachii on the inferior surface. So now it's another close-up of our rotator cuff muscles. Three of the four, supraspinatus above the spine. We've taken the deltoid muscle off here so we can expose this. The infraspinatus underneath the spine, below the spine. The teres minor right there, again located on the infraspinous fossa. And then this is the teres major here, but that is not a rotator cuff muscle. So actually, label this. So it's good. So these are 3 of the 4. The 4th one's on the posterior surface of the scapula. Supraspinatus, infraspinatus, teres minor. The subscapularis is on the other side. There's the subscapularis right there in the subscapular fossa. So it inserts on the head of the humerus. The supraspinatus inserts in the head of the humerus. So do the teres minor and the infraspinatus. They all 4 insert on the head of the humerus. And again, there's 3 of the 4 right there, but the subscapularis on the other side. On the other side of the scapula. So this is movement of 3 of the 4 muscles. This shows you the infraspinatus and the teres minor back here. You know, their actions are to pull the humerus back, you know, in a posterior direction. Here is the subscapularis over here, pulling the head of the humerus in an anterior or forward direction. The one we don't see is the supraspinatus that would come down and anchor right here, pulling the arm up. And here we see the supraspinatus inserted on the head of the humerus, pulling it upward. It contracts, the arm elevates. When it relaxes, the arm goes back down. The subscapularis is located here, and the infraspinatus and teres minor would be visible or on the other side here of the glenoid cavity. So here we see the supraspinatus. It pulls in different directions. It pulls, on the top of the humerus, and it can cause it to move in just about any direction. Because we've also got the teres minor and the infraspinatus located here, pulling this way, pulling backwards too. There's the teres minor right there. There's the infraspinatus right there, both pulling. And remember, these muscles don't operate in a vacuum. All 4 muscles are working together to create a range of motion that is almost a full 360 degrees around the glenoid cavity. There's the subscapularis pulling towards the front. Here we see the action of the the infraspinatus and the teres minor pulling on the head of the humerus. We don't see the supraspinatus or the subscapularis, but they're there too. Now, problems with the rotator cuff muscles is they wear out. They wear out over time. We see a lot of older individuals, elderly individuals that have rotator cuff injuries from wear and tear. They manage to tear the tendon, one of the tendons that attaches it to the head of the humerus. That's through wear and tear. The tendon becomes inflamed, the tendon becomes torn. It becomes very painful to move their arm. It can be through wear and tear. It can be through blunt force trauma. A fall can do that. And it happens. And then surgery can be easily repaired. Rotator cuff surgery is a very common surgery among older individuals. It's also very common among younger adults too. Late adolescents, early adults, mostly from sports injuries, contact sports in particular, wear and tear injuries. It's not unusual to have rotator cuff surgery repair the damage caused, particularly in contact sports. So we have these 2 age groups, younger adults and older adults, that are both going to end up having rotator cuff surgery. Again, usually because of a tear of the tendon that attaches the rotator cuff muscle to the head of the humerus. They can become inflamed, they can become torn. When that happens, the range of motion and the mobility is significantly reduced, and you can get it back by having surgery. And here we see a torn supraspinatus tendon. Again, wear and tear will cause this to occur. It happens. They wear out over age because we use our shoulder muscles constantly. We use them all the time. These tendons probably tear with greater frequency than the Achilles tendon does, because tendons usually don't tear. But these will wear out over time in some people. So, okay. Now let's take a look at the leg. I put all the muscles together on this illustration to make it a little simpler. But let's take a look from the first one we saw was the tibialis anterior. Tibialis anterior is adjacent to the anterior crest of the tibia, immediately on the lateral side of the anterior, of the tibia. Particular landmark is the anterior crest, the sharp edge, the shin bone. Immediately to its lateral side is the tibialis anterior. So if you're looking straight on, you can see the lateral side of where the little toe is. You see the anterior crest. The tibialis anterior is immediately to the lateral side of the crest. What's it do? It causes the toes to spread out and to flex. Because when we take a step, our toes spread out to stabilize our position, and our toes flex to give us a firmer grip of what we're standing on. There's the tibialis anterior. Now above that, there's a very large muscle called the tensor fasciae latae, also running along the lateral side of the leg. It's a very large muscle, extends all the way down past the patella right there. Here we have the extensor digitorum longus. Extensor digitorum longus is immediately adjacent to the lateral side of the tibialis anterior. What does it do? This one, I apologize. I got dorsiflecting and extending the toes. Let me back up. Tibialis anterior does not spread the toes. The extensor digitorum longus spreads the toes and then flexes the toes. The tibialis anterior causes you to raise your toes. Because when we walk, we go heel down, toes up. Then we go heels up, toe down. We walk heel and toe like that. We're not aware of it. We don't pay attention to it because if we did, we'd fall down. The tibialis anterior causes the foot to dorsiflex, meaning excuse me, the toes come up. When the toes go down, it's because the heel has come up. When the toes go down, the extensor digitorum longus then spreads the toes out and causes them to flex. They flex when they spread out, they flex to give a better grip on what they're standing on. And we don't notice it when we're wearing shoes, but if we're barefoot, for example, or wearing sandals, we might see our toes spread out if we stop to look. There's always a risk of falling on your face if you stop and look at your feet while you're walking. And not only do they spread out, but the ends of the toes will flex and try to grasp better onto the surface. So these two work together to enable us to walk. Tibialis anterior dorsiflexes the foot, and the extensor digitorum longus, when the toes go down, they spread them out, and the ends of the phalanges and the toes flex. Behind the extensor digitorum longus is the peroneus longus. The peroneus longus and the peroneus brevis are both involved in stabilizing the foot and spreading the toes. There is the peroneus brevis, characterized with this little yellow area right there. They are on the lateral side of the leg. On the little toe side, they work with the extensor digitorum longus. We also see at the top of the leg, we have the Gluteus Maximus. Arguably the largest muscle in the leg. It is often referred to sarcastically as the monitor of the butt muscle or the cheek, the butt cheek muscle, or something like that. It does have a purpose, and that is to help to flex and extend the thigh. We don't think about it a lot for those roles. We usually sit on it. So, here we have the soleus muscle, and which is immediately adjacent to the gastrocnemius. The gastrocnemius is the large calf muscle that is responsible for what we call plantar flexion, raising our heel. And there is the gastrocnemius right there. The soleus is directly underneath the gastrocnemius. And then the gastrocnemius attaches to the calcaneus bone in the foot by way of the Achilles tendon right there. Very powerful tendon. When our gastrocnemius muscle contracts, it pulls on the Achilles tendon, which pulls on the calcaneus, which raises our heel up, and then our toes go down. That plantar flexion is raising the heel. Dorsiflexion is raising the toes. When the toes go up, the heel has to go down. When the heel goes up, the toes have to go down, and that's how we walk. There's the tibialis anterior. It is on the front of the tibia. It causes us to dorsiflex and invert the foot, meaning we raise our foot up, the toes go up, and our heel goes down. Plantar flexion is just the opposite. Plantar flexion, the heel comes up and the toes go down. The antagonist of the tibialis anterior is going to be the gastrocnemius. Because the gastrocnemius causes just the opposite action. Now, Gluteus Maximus, large muscle at the top of each leg. Gluteus Maximus extends the thigh, so we can increase the angle away from the thigh, thanks to the Gluteus Maximus. It is not where we give injections, because the greater sciatic nerve runs right underneath the Gluteus Maximus, right in here, and it's a very large nerve. It's about the size of your finger, and you don't want to hit it with a syringe. Instead, we find a landmark off the iliac crest right here, a muscle called the gluteus medius. And if you have a maximus, you're nearly always going to have a medius anyway. And there is even a gluteus minimus, but the gluteus medius is about 2 fingers width away off the iliac crest here, and that's usually where in this location here is where we tend to get our injections in our hip. So we'll try to avoid any unpleasantness with hitting the sciatic nerve. In the front of the thigh, on the anterior surface of the thigh, we have the 4 muscles called the quadriceps. And their antagonists are going to be the hamstrings on the posterior surface of the thigh. So the quads, 3 of the quadricep muscles share the same name. There is the vastus medialis on the medial side, the vastus lateralis on the lateral side, the vastus intermedius in the middle, and on top of the vastus intermedius, we have the rectus femoris. There's the vastus intermedius right there. So here we see the vastus medialis, the vastus lateralis, the vastus intermedius, and the rectus femoris. Remember that the big toe side is always the medial side. As long as you know where your large toe is, the great toe, as long as you know where that is, then you know that's the medial side, because the foot can't turn over like our hand can. So the great toe is always on the medial side, the little toe is always on the lateral side. So the vastus medialis is on the medial side, the vastus lateralis is on the lateral side, and the vastus intermedius is in the middle with the rectus femoris on top. So these are the quadricep muscles. Their action is to flex the thigh. So the thigh will bend. We bend the thigh. The other action is to extend the lower leg. So we flex the thigh at the knee, and we extend the lower leg like we're kicking out, like we're kicking a football. We're kicking out in some way. That is extending the lower leg. That's what the rectus femoris and the other three quadricep muscles do. The quadricep muscles allow us to flex our thigh and extend the lower leg, like we're kicking a football out. So because the leg, when we extend the angle, the arm straightens out when we extend the arm at the elbow. The leg straightens out when we extend the leg at the knee. So we extend our lower leg using the quadricep muscles. The hamstrings are the three muscles on the posterior surface directly below the gluteus maximus. We have the biceps femoris on the lateral side of the thigh. So the biceps femoris is over here on the lateral side, the little toe side down here, little toes down here. Then we have the semitendinosus and the semimembranosus stacked together on the medial side. Two ways to remember their location. Semitendinosus, the T, should make you think that it's on top of the other muscle. The other muscle is the semimembranosus, and it's on the medial side. Think of the M there. So tendinosus and membranosus, they are on the medial side. They are stacked on top of each other. These are the three hamstrings. Well, there are 4 quads and 3 hamstrings. What do they do? Well, there they are here on the model. And you can see the biceps femoris is on the medial side. And the semitendinosus and the semimembranosus are on the biceps femoris on the lateral side, the semitendinosus and semimembranosus are on the medial side. So if you're looking at the posterior surface of the thigh and you see these two muscles stacked together, they're on the medial side. The biceps femoris is always on the lateral side. So anyway, semimembranosus is underneath here, shows up there and there. There's a little groove you can see here. And if we were in lab, most of the models that you see, I've drawn a dark line with a Sharpie down through this groove, so you can, on both sides, so you can see exactly where the distinction is between them, not in these pictures. Anyway, semimembranosus is underneath the semitendinosus. Semitendinosus is on top. Think of that T for top. Okay. Now, what do the hamstrings do? Well, they do the exact opposite of what the quads did. The quads flex the thigh, cause the thigh to bend, and they extend the lower leg, they kick out. Well, here with the hamstrings, instead of flexing the thigh, you extend it. You stick the thigh out, and you bend the lower leg. You flex the lower leg, so you bend the leg back. So it's just the exact opposite of what the quadriceps do. The quads are going to extend the lower leg, kicking that football. The hamstrings are going to bend the lower leg and bring it back. They're going to bring your leg back so you can kick it again. So maybe you're kicking a soccer ball. Maybe you kick a soccer ball and you flex your leg to kick the ball out. You flex your lower leg to kick the ball, and then you draw your leg back again to kick it again. Well, the quads and hamstrings have to work together. The quadriceps allow you to extend your lower leg, kick the ball. Well, your leg's sticking straight out there now. How do you get it back to do it again? The hamstrings allow you to flex the lower leg, bring your leg back so you can kick it again. So you're using both sets of muscles together here. You kick with one leg and you reload with, you kick with one set of muscles and you reload with the other set of muscles. Kicking out, bringing back, kicking out, bringing back. Because if you can't kick, you can't extend the lower leg and kick the ball again unless you flex your leg and bring it back. So the hamstrings are the opposite action to the quadriceps, but they work together. Here we can see, and when one set of muscles is contracted, the other is relaxed. When the hamstrings are contracted, the quads are relaxed. When the quads contract, the hamstrings have to relax. And so we see this action going on here. Just think of kicking that soccer ball. You got to extend the leg to kick it, and you got to flex the leg to reload to kick it again. Now on the medial surface of the thigh, we have 4 different muscles that are involved here, usually allowing us to flex our thigh, extend our thigh, stabilize our thigh, sit cross-legged on the floor. We have the Sartorius muscle. First of all, the Sartorius muscle is most unusual shaped muscle we have. It's shaped like a strap that runs down across the anterior surface of the thigh all the way into the medial surface. This is the muscle that allows us to sit cross-legged on the floor or on the ground. We've also got, there we go, the gracilis. The gracilis runs from the the groin area all the way down to the knee on the medial side of the thigh. We have the adductor magnus and the adductor longus. The adductor longus runs underneath the sartorius, adjacent to the gracilis, and the adductor magnus runs also adjacent to the gracilis, underneath the underneath the gracilis, and underneath the sartorius. So there's our gracilis on the medial side of the thigh, and it allows us to work with all the other muscles to flex our thigh. There's our sartorius, runs from the ilium, all the way from the ilium down to the tibia, but it bends down across on the medial side here. It helps to stabilize our thigh, and we particularly use this muscle when we're trying to sit cross-legged. There's our adductor longus right there, adducting the thigh, meaning moving the thigh into the midline. And then we have the adductor, let me get back to the adductor magnus. Is this one over here, not labeled, but this is it right here. It runs underneath the gracilis and underneath the sartorius. And its role is to help stabilize the thigh. Okay, now the gastrocnemius. There's our gastrocnemius. It has 2 heads, a lateral head on the little toe side and a medial head on the great toe side. These heads originate on the medial and lateral condyles of the femur, the medial and lateral condyles of the femur. The medial head of the gastrocnemius comes from the medial condyle. The lateral head of the gastrocnemius comes from the lateral condyle. That should be obvious, but I'll just say it anyway. Okay. There's our Achilles tendon right there. It inserts, this attaches the gastrocnemius muscle to the calcaneus, because the role of the gastrocnemius is to elevate the heel. Plantar flexion, elevating the heel, part of our walking process. There's the Achilles tendon. And again, the gastrocnemius, the calf muscle, the tendon, also called the calcaneal tendon, if you will. It inserts in the calcaneus bone, plantar flexion of the lower leg and flexing the lower leg. Because you're pulling, think about it. When you elevate the heel, the heel comes up and your leg is flexing, but plantar flexion, the foot rises up. And we have to have dorsiflexion and plantar flexion for us to walk. We don't see it when we walk, but that's exactly what we're doing. Okay, so origin on the condyles of the femur, the medial and lateral condyles of the femur, insertion on the calcaneus, plantar flexion and flexing the lower leg. This is what the gastrocnemius does. And again, medial head on the great toe side, lateral head on the lateral toe side, on the little toe side, little toe side. There is our soleus tucked underneath, and there is our Achilles tendon or calcaneal tendon, and it inserts on the calcaneus. And what it does is allows plantar flexion. When it contracts, it elevates our heel. Our heel comes up. Our leg flexes. The lower leg flexes when we do that. But we elevate our heel, and that points our toes down. Now, to take the next step, we have to raise our toes and drop our heel. And that's where the tibialis anterior comes into play. So, plantar flexes the foot, flexing our lower leg. So, and again, this is what it looks like. This is dorsiflexion, raising the toes and lowering the heel. And here's plantar flexion, raising the heel and lowering our toes. Moving into the torso. We've got a number of muscles here that are just for expression, like the one that nobody ever gets wrong, the frontalis muscle, right there. Very, very thin muscle. You know it's thin. If you rub your forehead, you can feel the bone. You can feel your frontal bone underneath. That means that you've got a layer of skin and you've got your layer of muscle there. There's not much muscle there, and its only purpose is to show expression. Barely protects the skull. So there's the frontalis. Around the eyeballs are the orbicularis oculi. Flat circular muscles have nothing to do with vision, have everything to do with showing expression. Same as the orbicularis oris around the mouth, showing expression. Here's muscle that does do something. That's the sternocleidomastoid. We see part of it here. The sternocleidomastoid is the one that allows us to turn our head to the left or turn it to the right. Zygomaticus muscle, expression. Two little bands of muscle right across there attached to the zygomatic bone, but also for showing facial expression. You can see the zygomatic muscles right there. Now, let's take a look at this again. Here is the frontalis, right on top of the frontal bone. All it does is show expression. Orbicularis oculi, ocular for oculi for ocular around the eyeball. Orbicularis oris for oral. And that is the flat circular muscle around the mouth. Here's our frontalis, and it's, as I said last week, it's interesting to note that when the frontalis muscles formed, it formed as two parts. It never fused together into one like the frontal bone did. So, but there's the frontalis muscle. There are the orbicularis oculi and oris. You can see just how flat they are. There's not much to them, but their role is to show expressiveness and expression around the mouth, around the eyes. Here we see one of our chewing muscles. This is one of the facial muscles that works. This is the masseter. This is what, when that contracts, it pulls the mandible up against the maxilla. Maxilla doesn't move. The mandible does. The teeth of the mandible are brought up against the teeth of the maxilla for chewing. This is where digestion first starts in our mouth. We start chewing up, we rip and tear and shred and grind. the food that's in our mouth, whether it's grains or greens or meat or fruit or whatever it is. We're ripping and tearing, we're shredding and grinding. Our teeth are designed for different purposes, and nothing happens unless the mandible can be brought up against the maxilla, and that's what the masseter does. There's the zygomaticus muscles there. Again, they're expressive muscles. They're set in a pair like that. Here we see the sternocleidomastoid. We can see its origin. One of its origins is down here on the clavicle, and the other origin is on the sternum, and it inserts back here at the mastoid process, that bump right behind our ear on each side. Sternocleidomastoid. So there we are. Origin on the manubrium of the sternum and on the clavicle. Inserts on the mastoid process. When both muscles flex, when both muscles contract, the head will flex, and so your head will bob up and down. If one of the muscles contracts, the head turns in the direction of the contraction, because you're pulling on the mastoid. When you contract the muscle, you pull on the mastoid and the head turns. We flex and rotate the head. We only flex if both of them contract at the same time. Very powerful muscles here too, large, powerful muscles. Head rotation. Whatever side that we contract is the side or direction we're going to turn. And as I showed you last week, if both muscles contract, the head nods up and down. And while this would be interesting, we don't usually get this. We don't rotate our head all the way around. So anyway, but it's getting close to Halloween. Okay. Now, another chewing muscle is the temporalis muscle, located on the temporal bone. This is another working muscle here. The temporalis has its origin on the temporal bone, its insertion on the mandible, just like the masseter. And it also pulls the mandible up against the maxilla. There's the temporalis, there is the masseter. Both of these are chewing muscles to bring the mandible up against the maxilla. So there's the masseter, its origins on the zygomatic arch, and its insertion is on the mandible, elevating the mandible, causing us to chew. The temporalis origin is on the temporal. It also inserts in the mandible, elevating the mandible, allowing us to chew. Yeah. There's the masseter. Elevate the mandible. Whenever the mandible contracts, whenever the masseter contracts, the mandible is brought up against the maxilla. The temporalis is in origin on the temporal bone and insertion on the mandible. It allows us to elevate the mandible also. And you can see, because we're talking about this in lecture right now, with acromegaly. Acromegaly causes the facial bones to enlarge, and it alters the size of the mandible. The mandible enlarges, the maxilla enlarges. Individuals with acromegaly often have great difficulty speaking clearly because of the size of these bones. Now, these bones have enlarged because we shape our words and we make sounds by manipulating the air coming out of our lungs with our tongue, our teeth, and our jaws. And if the jawline, if the mandible is altered in its shape, or if the maxilla is altered, it alters the type of sounds that we make. We'll see this we'll talk about this a lot in AP2. Anyway, so there's the temporalis. It pulls the mandible up against the maxilla. And the mechanism of chewing, raise the mandible up against the maxilla. It looks like this. So we see the the same number of teeth and the same type of teeth are in the maxilla as are in the mandible, and their role is to cut and to rip and tear and crush and grind, depending on the foods that we're eating. Moving below the head, we go into the torso and the abdomen. We see right away, of course, there's the trapezius muscle, sits above the shoulder, above the scapula, and down the back. It's a very large triangular shaped muscle on either side of the neck and down the back. We see a very large muscle in the front of the chest called the pectoralis major, and its counterpart is the pectoralis minor. And often the direction of the muscle fibers that make up the muscle run in opposite directions when we have a major and a minor overlaying each other, or an external and an internal overlaying each other. The fibers that make up the individual muscle cells will run in opposite directions, and it gives them more strength. So there's the pectoralis major, and there is an important muscle called the diaphragm, separating the abdominal cavity from the thoracic cavity. Pectoralis major, large muscle on the anterior surface of the thoracic cavity. It sits on top of the ribs. It inserts itself on the humerus. It allows us to rotate our arm, adduct our arm. We use it when we climb. We use it when we throw things. We use it when we do push-ups. So if you're throwing a baseball or a football, if you're climbing a rock wall or climbing a ladder, if you're doing push-ups, any number of items here, activities like that, you're going to be using your pectoralis major. Or any action that's similar to that will involve the pectoralis major. Very large, powerful muscle. We often refer to it as the pecs. Of course, we can see there. We can see where its insertion is on the humerus. Now, trapezius, a triangular-shaped muscle on the upper back. It inserts. It attaches to the skull and to the scapula and to the vertebrae. It causes us to, when it contracts, we raise our head up or we move our scapula up, like we're shrugging our shoulders or we're raising our head. It will also allow us to lay our head, tilt our head down to either side, not nodding our head, like not turning our head like the Sternocleidomastoid does, but to tilt our head over. So the action of the trapezius: elevate the shoulders, flex our head, back and front, and also tilt it over from side to side like that. So we can tilt our head from side to side, or raise our head up, elevate our scapula, raise our head up to look around, to shrug our shoulders. There's all sorts of actions we do here that we're totally unaware of. But we use the trapezius for those actions. Very, very big muscle here. Not the biggest on the back muscles, but one of the bigger ones. Now, Latissimus dorsi is even larger. It's formed below the trapezius. This is a very powerful muscle. It inserts itself on the humerus. It gives us great strength when we are, like, for example, this is our working muscle. We drive nails using a hammer with this muscle, an overhand swing to pound a nail, to chop wood. We use this, to throw a ball, to throw a softball underhand. And there's a tremendous amount of power you can get behind that. So there's a lot of actions we do using the latissimus dorsi. Its strength is transferred directly into the humerus. So whether it's an overhand throw, an underhand throw, a over the shoulder throw like driving a nail or chopping wood, we are using the Latissimus Dorsi. And there's our Latissimus Dorsi there. You know, the trapezius doesn't show well in the model, but there's the trapezius there, just the edge of it, and also extending up here towards the neck. And the Latissimus Dorsi is from here, this groove, all the way down to here. And this is the kind of action that we see. You know, whether you're bowling or throwing a softball, you know, any kind of action, underhand or overhand, because the power is being directed to the humerus from the Latissimus Dorsi. So you can get a lot of force behind that action. Okay. Moving lower, we have the Serratus Anterior. It helps to stabilize the thoracic cavity and the abdominal cavity. There's our pectoralis major, and you can see here is the pectoralis minor right underneath it. Here we have our rectus abdominis. It allows us to flex the abdomen. It pulls these 6 muscles called the six-pack. When they contract, they pull the abdominal wall in. We find that when we do this when we're going to pick up something very heavy. We do it to stabilize the abdomen, to give us more strength. We find that when we do pick up something very heavy, we tend to hold our breath. We also use this when we're straining. We want to pick up something really heavy. Or when you have a person that's constipated and trying to force their bowels to empty, and they're straining to empty their bowels. Or when a pregnant woman is straining and pushing down, she's compressing to force the baby out. She's compressing her abdomen using her six-pack here. And we find, though, that doing so, we tend to hold our breath. And we tend to get, if we strain too hard, we tend to get a little dizzy, you know, when we do that, because we're getting a little short of breath there. It also slows down our, raising the pressure in the abdomen like that when we compress the abdomen, causes our heart rate to slow down a little bit too. Yeah. Makes it difficult to breathe because if we compress the abdomen, diaphragm, if we're flexing the abdomen, diaphragm doesn't have room to come down. So when we see when the abdomen is flexed, then it becomes firmer and more rigid. We do this when we're going to pick up something very heavy, or when we're straining. We even do it when we cough. When we cough very violently, you've got bronchitis or something, and you're coughing, and you know you cough. So if you've ever coughed so hard it hurts, well, that's, you know, you're flexing the rectus abdominis muscles. External obliques are on the side of our abdomen. You want to know how exactly where. Place your hands in your front pockets, point your fingers towards the midline, and that's the location of your external oblique muscles. When they contract, they also compress the abdomen for you. And the internal obliques are directly underneath the externals, but they're running in the opposite direction. Compressing the abdomen is the role of the external obliques. So usually what happens is you use the rectus abdominis to flex the abdomen, to draw those muscles in, and then you're compressing the abdomen on the side with the external obliques. And here we see them here. Again, the serratus anterior. The external intercostals. These are the muscles between the ribs. When you eat ribs, you're eating intercostal muscles, by the way. There is the rectus abdominis again. And here are the external obliques. And the internal obliques are directly underneath them, but the fibers in the muscle cells run in the opposite directions. Notice that's pretty obvious here in the external intercostals. The fibers in the external intercostal muscles are running towards the sternum. The internal intercostals, which are underneath their muscle fibers are running in the opposite direction. Underneath the torso, there are the internal intercostals, and if you look carefully, you can see that the fibers run away from the sternum. There, that little red line are the internal obliques. Can't tell much by looking at it, but there they are. There is the transverse abdominis, and that little line is the diaphragm. The diaphragm actually is much bigger than that. It is shaped like a parachute. It's a very large muscle separating the abdominal cavity and the thoracic cavity. External intercostals there, going towards the sternum. Internal intercostals moving away from the sternum. The externals are on top. The internals are underneath. The external intercostals, when they contract, they elevate the ribs and the thoracic cavity gets larger. The diaphragm drops. The whole thoracic cavity enlarges. The lung volume increases and the air pressure inside the lungs drop and air rushes in. That's how we breathe. When the internal intercostals contract, they lower the ribs and the diaphragm comes up. The thoracic cavity volume drops, the lung volume drops, and air goes out. And since the lungs are glued to the inside of the chest wall, they have to do what the chest wall does. So the internal intercostals depress the ribs. Of course, there's your diaphragm. The diaphragm contracts, it drops down, increasing the volume of the thoracic cavity. When it relaxes, it rises up like this. Diaphragm is located, if you find the xiphoid process, then you know where your diaphragm is located in the front. And we see here, there's the diaphragm. When the lungs inflate, the diaphragm is going down. When the diaphragm relaxes, the entire chest cavity shrinks. Diaphragm goes up, ribs drop. Diaphragm goes down, ribs expand. You can see it here. As the ribs rise, the diaphragm will go down. When the ribs rise, the diaphragm goes down, and the thoracic cavity enlarges, and the volume of air, the volume of the lungs increase, and air rushes into the lungs. And that is our second review of muscles. Any questions on that? Okay, I'll get this posted today. And then again, the muscle test is due by no later than December the 9th. Don't wait till December the 9th to take it. Just take it, before then. So, because I don't, like I said, I'll just keep saying this. I have no flexibility on this. So, okay. So, y'all have a good rest.